Hello everyone. Now I am starting with a case. A 54-year-old male with history of chronic alcoholism admitted at our hospital with recurrent blood vomiting from last 6 hours, and he had taken his last episode of alcohol with 8 hours back, and no history of similar episode is given. And no history of diabetes is and hypertension is seen. And when there is, I had examined him. It was jaundice. There was jaundice, pallor, and pallor grade 1. BP was 100/60. Pulse rate was 98 per minute. Chest was clear, but JHP was raised. And no local bleeding was seen. And in abdominal examination, there was ascites, massive splenomegaly, and bipedal pitting edema, venous engorgement. In that engorgement, the flow was away from umbilicus, and abdomen was non-tender, but massive splenomegaly was seen. And bilateral on examination, there was bilateral swelling, spider nevi, dupuytrenine contracture in right hand is noted. DCS was 15/15, and no history of sleep alternance is seen. These are the scene. Sorry, these are the scene. This jaundice. These are the dupuytrenine contracture, jaundice, and parotid swelling. And these are the spider nevi and tense ascites. On investigation, we had seen in blood there was a thrombocytopenia, microcytic hypochromic anemia, hemoglobin level was 9, and TLC was 4000, AST was 400, ALT was 150, and sodium was 120, and albumin was 1.1 gram per DL. Urea was 20. Sorry, creatine was 1.1 gram per DL. It was the blood report of day 1. PTA, APTT, and INR raised when we had sent acidic fluid for analysis. Sag ratio was 1.4, and protein was 2, and ADA was 30 per liter. In a upper GI endoscopy, liver was sunken and splenomegaly noted. Upper GI endoscopy, there was the esophagus varus and endoscopy guided portal venous Doppler. No clot was seen in portal vein. When patient was treated at our hospital with propanolol, furosemide, and spironolactone, as well as there was a terlipressin was also given, and spironolactone was given in 400 milligram per DL, and furosemide was given 160 milligram per DL. It was started from beginning dose, and it gradually increased it in up to day 3. Okay, day 4 gradually increased, and see, he was allowed for salt restricted diet from day 1, and in day 4 creatinine was raised 3.2, and USG KUB was and USG KUB, there was the kidney size was mild raised, and no obstruction was found. No obstruction in kidney bladder was found. So probably it's a case of portal hypertension due to decompensated liver failure in due to chronic alcoholism. I am explaining this case. A 54-year old male. There was a history of chronic alcoholism, and there is a history of the recurrent blood vomiting from say 6 hours. And as on examination, there was ascites, massive splenomegaly, and ascites, splenomegaly, and recurrent blood loss. So this is the and this is a case of if there is a trait of refractory ascites and massive splenomegaly and varicose bleeding. It's a case of portal hypertension. Okay. And now I am want to tell one thing: refractory hypertension. So we had in a case when the ascites is not subsided with salt restriction and full dose of spironolactone and furosemide. Full dose of spironolactone is 400, and furosemide is 160. So after full dose of spironolactone and furosemide. If ascites does not decrease, that is the refractory ascites, then we will go for large volume peritoneal synthesis and or for tips. Okay. So and another thing you can notice that there is in a case of recurrent blood vomiting. So recurrent blood vomiting is in a chronic alcoholism patient. There will be some DDs, like there is the Mallory West DR. There can be the peptic ulcer, and there can be the portal hypertension due to decompensated liver failure and cirrhosis, and there can be coagulopathy because liver is damaged, and you know that most of the clotting factors are produced from the liver. So due to that, bleeding can occur. And jaundice, and there is a jaundice ascites. So it is a case of decompensated liver failure, and JVP is raised because the JVP is raised with portal hypertension. So here we can also see the DDs, because in this slide you can see the causes of the portal hypertension. There are the some prehepatic causes. There are portal venous thrombosis, sorry, splenic venous thrombosis, and massive splenomegaly. There are some hepatic causes. So portal venous hepatic causes. There is the pre-sinusoidal, like cystosomiosis, congenital hepatic fibrosis, and sinusoidal causes. There is the cirrhosis, alcoholic hepatitis, and post-sinusoidal causes. There is the hepatic sinusoidal obstruction, and post-hepatitis causes most important. There are some Buchiari syndrome, inferior vena cava obstruction, and cardiac causes like restrictive cardiomyopathy and constrictive pericarditis and severe congestive heart failure. So here you can see the JP is raised, and so there will be two DDs. Number one, right heart failure, and sorry, and portal hypertension due to these causes. And another thing is, second thing, that is the portal hypertension is due to portal hypertension. Ascites is there, and decompensated liver failure and portal hypertension, ascites is there, and for due to massive fluid overload, JEB is raised. But if so, how can I differentiate? If there was a right heart failure, and due to the portal hypertension developed due to right heart failure, we can know there is a tender large enlarged hepatomegaly. But here we cannot palpate any liver, and there is another thing. We can see that here the sag ratio is 1.4, means there is a portal hypertension, increase the portal hypertension. But so in when a case of the ascites will come, we will approach it by, first we will see the sag ratio. Then in sag ratio, if it is sag is more than 1.1, then we will tell that it is a case of portal hypertension. And if the sag ratio is less than 1.1, so portal hypertension is not there. So if some causes of low sag ascites are biliary leak, nephrotic syndrome, pancreatitis, and peritoneal carcinoma, and tuberculosis. In high sag ascites, when there is a portal hypertension is there, then we will see how much the protein level is. If the ascitic protein level is more than 2.5, the causes of more protein are congestive heart failure. There is the Buchiari syndrome, IVC obstruction, and sinusoidal obstruction, means most of the post hepatic causes. And if the protein is less than 2.5, it is due to cirrhosis of liver mets, and late Buchiari syndrome. In early Buchiari syndrome, protein is more than 2.5, and late Buchiari syndrome, protein is less than 2.5. Okay, so here you can see that protein is 2, means less than 2.5. So if it is due to heart failure, so protein will be protein level should be more than 2.5, but it is due to heart liver failure, so it decreases. And in the blood pictures you can see that thrombocytopenia, microcytic hypochromic anemia, and TLC count is decreased. So it is a case of pancytopenia. Pancytopenia is developed due to portal hypertension, and the portal hypertension hyperspleen actually is developed due to the hypersplenism of portal hypertension, because splenomegaly occurred in portal hypertension, and due to hypersplenism of portal hypertension, three cell lines are decreased. And here you can see that albumin level is decreased, and so globulin level will be increased, and Ag ratio will increase. Albumin level is serum albumin level is increased due to liver failure. And another thing you can see that urea level is decreased, because urea is urea is produced at our liver by ornithine cycle. So when there is a chronic liver disease, so sorry, when there is our chronic liver disease develops, urea level will also decrease, and especially in the cirrhosis phases. And AST is more than ALT, more than twofold of ALT, so it's a case of alcoholic. And alcoholic, because if AST is more than twofold of ALT, there are some causes like heart due to, it may be due to the cardiac cirrhosis, it may be due to alcoholic cirrhosis, it may be due to Wilson's disease, and it may be due to some drug induced. So here you can see that sagress is, in portal hypertension, in acidic fluid sagress, you can see there is a portal hypertension, and the protein is 2, so it is a protein is less than 2.5, so it is not due to cardiac causes, it is due to cirrhosis causes. Okay, and another cause, there is the clinical picture is going through the liver disease. And another thing you can see that bilateral parotid swelling, spider nevi, dubitra, and contracture, and these are the clinical features of chronic alcoholic liver disease. Okay, and rest of that, in chronic alcoholic liver disease you can see there is the gynecomastia in male, there is the hypogonadism, and loss of pubic hairs. Okay, and the GCS is 15 by 15, and no sleep alternance is seen. GCS is 15 by 15, and no sleep alternance is seen. So so the patient in hepatic encephalopathy is not developing. So it's a good stage. So in hepatic encephalopathy in grade 1, there is a sleep alternance develop, and patient develops some calculation problem. In from grade 2 and grade 3 we can see astrexia. Okay, and no local bleeding is seen. So below the PTPT is raised, so we need not to intervene for fresh frozen plasma now. And in endoscopy guided portal venous Doppler, we had seen no portal no clotted, so portal vein, no obstruction in portal vein is seen. And day 4, it is creatinine is raised in 3.2, and in USG QEB we had seen that size is mildly raised, and obstruction is not no obstruction found, means there is no hydronephrosis, and so it is a AKI is developing, and it's a case, absolutely it is a case of sorry, hepatorenal syndrome. Because in hepatorenal syndrome, actually the kidney disease AKI occurs due to due to the furosemide uses and large peritoneal synthesis in the case of the uh, chronic liver diseases. So to diagnose hepatorenal syndrome, so we should diagnose that there should be the creatinine is decreases day by day, and urine production is decreased, and we should rule out that there is the no other causes of renal parenchymal disease. So in kidney in USG there is seeing that there is no other kidney disease, and patient has no history of the kidney disease. So we can see that we can tell that hepatorenal syndrome is developing. So treatment of hepatorenal syndrome, that we will so decreases the dose of furosemide first, then we will decreases, then if not patient it improves, then we will stop furosemide for some days, and we will avoid the large volume peritoneal synthesis, and we will infuse the albumin, and if not also, then we'll give darlipracin midodrine like drugs. So I am, before telling something about portal hypertension, I am telling the anatomy of the portal vein. Actually, portal vein is the portal vein forms the portal vein supplies maximum blood supply of the liver, and portal vein is made by splenic vein and superior mesenteric vein at the level of neck of pancreas. Okay, it is the CEO the portal trait. Portal trait is from in histology. You will see it is the liver sinusoid, and in liver sinusoid it is the portal trait. Portal trait is formed by hepatic artery, hepatic vein, and bile duct. So liver blood flow is supplied maximum 80% by portal vein and 20% by hepatic artery. So liver has a dual blood supply, and these portal sinusoids comes in the central veins, and central veins forms two three major vein, right, middle, and left, and these forms the portal vein. So when we'll see the portal vein, if the portal when the portal venous when the hepatic venous pressure hepatic venous pressure gradient is more than 5 millimeter of mercury, that is called the portal hypertension. So portal hypertension is developed either due to increase the interhepatic resistance or due to increases the plaque blood flow. So most common cause of portal hypertension in our country is in our country and USA also the cirrhosis of liver, rather than that some coagulation disorder, disorder like protein C, protein A, antithrombin factor 5 deficiency, and cell thrombocytopenia causes the coagulation in splenic vein and causes the portal hypertension. This slide I had explained previously. So these are the causes of portal hypertension. Portal hypertension is seen in the pre-hepatic, hepatic, and post-hepatic causes are there, and in hepatic causes, pre-sinusoidal, sinusoidal, and post-sinusoidal causes are there. I had explained it previously. Now, when the portal venous pressure is increased, so portosystemic anastomosis is done for decreasing the pressure. So these are the sites of the portal systemic anastomosis. So esophagogastric junction, umbilicus, rectum, retroperitoneal, splenic. Actually it is done in the rectosigmoidal junction, paraesophageal, splenorectal, and retrogastric. I had explained this that there is a three complaint of the portal, the clinical pictures of portal hypertension. There is the gastroesophageal varices that causes the hemoptysis, sorry, hematemesis. refractory ascites and hypersplenism. Refractory ascites I also explained previously, and hypersplenism. Factor produces the gastric esophageal risk factor for producing the esophageal varices. Yes, are severity of the depends on the cirrhosis depends on the severity of the cirrhosis. Severity of cirrhosis is measured by the child plaques class. Okay, and the height and weight of the hepatic venous pressure, size of the varices, location of the varices, and certain endoscopic stigma, including the red wall sign, hemostasis spot, diffuse erythema, bluish color, cherry red spot, and white nipple spots. And the other rarely hepatic venous pressure or gradient is measured by intravenous radiological pressure. If the pressure gradient is more than 12 millimeter of mercury, it is a risk of varicose bleeding. So I want to talk another thing. You see it, if the hepatic venous pressure gradient is normal up to the 5 millimeter of mercury, and 5 to 10 it remains silent, but here also varices develop, and if it is more than 12, then varices will be ruptured, and it will be cause massive hematemesis. It is a pathogenesis of the ascites formation. How ascites is formed in cirrhosis. So when cirrhosis occurred, there is a portal hypertension develop and plaquenic vasodilation occur. And there is a when there is plaquenic vasodilation occurs, there is a underfilling. So most of the blood flows through the plaquenic vessels, and so in arteries the blood flow decreases, and arteries undergoes underfilling, and then so when there's arteries are underfilling, then renin angiotensin system of our body activates, and when our RAS activates, there the sodium retention occurs, and the plasma volume is expanded, and therefore an ascites is formed. Now there I am telling about the treatment of esophageal varices. When esophageal varices will become, so prophylactically we'll give the non-selective beta blocker. So there is you know the non-selective beta blocker, it will decreases our heart rate. So we'll target to monitor our heart rate between 55 to 60 beats per minute, and blood pressure 100 by blood pressure will be kept between the 100 by 60 and add-ons. So, and acute bleeding will be given a fluid, and blood cell will be and RBC will be given for hemoglobin monitoring. So target hemoglobin level will be 7 to 9 gram per DL. So PTINR will be monitored, but we need not to give FFP. PTINR will be I told that coagulation factors are produced from liver. So PTINR will be deranged in case of portal hypertension in liver cirrhosis. And most common causes, I had told previously, that most common causes of portal hypertension is also liver cirrhosis. So PTINR will also monitor, but FFP will not be given to correct the PTINR until and unless we will see there is some bleeding from other sides, like we had done some gel IV cannulation and gel co for giving fluid. Sorry. And so if any bleeding is occurring from that cannulation site, will obviously will give FFP uh, as soon as possible. But other than that they will not interfere with it, because PTINR will be changed in liver disease. We'll give the vasoconstricting agent, usually somatostatin and octreotide will be given, and prophylactic antibiotic usually ceftriaxone will be given, because there is the we will go to endoscopy, and as well as there is also a neutropenia, because three cell lines are decreased in portal hypertension due to hypersplenism. And in case of the endoscopy are the first choice for controlling and as well as the investigation of esophageal varices. So if there is there is a massive bleeding and sudden massive bleeding, we will do the balloon tamp node before endoscopy, and then transjugular transjugular intrahepatic photosystemic surge, that is called TIPS. And first line treatments to I had told quite ago that upper GI endoscopy is used the first line treatment of the diagnostic and as well as the therapeutic of the esophageal varices. We will do is the endoscopy guided varicose ligation, that is called EVL. The esophageal varices are ligated so that they cannot rupture and bleed it. And after doing the EVL, we will follow a case every 2 years interval for this disease activity and new if the new bleeders are developing. And in case of any cirrhosis, if no history of hematemesis is also there and no history of varices is also there, we will do routinely for screening esophageal varices, because there is a chance of total hypertension, and esophageal varices is one of the most serious complication, because when it will rupture, it will cause a massive blood loss and that will collapse the patient. When esophageal varices are extended, we seen by when we do the endoscopy, upper GI endoscopy, and when we see that esophageal varices are extended up to the proximal stomach, or bleeding varices are entirely within the stomach, so band ligation is often unsuccessful here. Here we will do the tips first. Recurrent varicose, if recurrent varicose bleeding is occurred, then tips should be performed for long-term prevention. Because if there is the if when we are doing the band ligation of warning bleeders, then total hypertension is also quietly increasing, because that part is also ligated. So, and if it is not controlled sustainably with medications, yes, and it is going to recurrent, so we need to a bypass way to reduces the total hypertension. So tips is preferred here, and tips should be predominantly monitored for with Doppler ultrasound for stenosis. And these are the assessment of the bleeding, and there is a decompensated cirrhosis, that is the monitored by child plaque score, and moderate large varices, and varices with stigma of bleeding. Here is the management of the flowchart of the recurrent varicose hemorrhage. So when there is a recurrent acute bleeding is there, we'll do the endoscopy therapy and pharmacological therapy of conservative beta blocker. And then if the bleeding is not controlled, then if the compensated liver cirrhosis with child plaque score A, will do the tips first, and then if it is not controlled, we will consider for transplantation, liver transplantation. But if the child plaque score is B or C, then we will transplant the evaluation, and then we will do endoscopic therapy and beta blocker, and we will consider for tips and liver transplantation. These are the management of ascites. So patient with a small amount of ascites, usually we manage with dietary sodium restriction. We'll do the at first we will when any ascites patient will come, we will tell him for ascites for dietary restriction of ascites, so dietary restriction of salt, and then we will give the spironolactone and furosemide, and will gradually increases the dose of spironolactone and furosemide, and the highest dose of spironolactone is 400, and highest dose of furosemide is 160. If it is not controlled after the dietary salt restriction and highest dose of spironolactone and furosemide, that is called refractory ascites, then we'll go for do for a large volume peritoneal synthesis, and if that is also not controlled, then we'll do for tips. So now I'll tell for hepatorenal syndrome. Due to diabetics in hepatorenal syndrome, I had explained previously. If it is developed, diuretics should be stopped, and infusion of albumin of 1 gram per kg per day is recommended. And then vasoconstriction like terlipressin and low dose norepinephrine are given. Midodrine and alpha agonist and octreotide is given. And in patient with either type 1 or type 2 hepatitis, prognosis is poor unless the transplant can be achieved within a short period of time. Another thing I want to tell, just for some DD of ascites. So if here there is the refractory ascites, massive splenomegaly and bipedal petechidae, sorry, uh, and varicose bleeding was there, so it is a case of portal hypertension. But some causes of if a patient comes with ascites, then we will evaluate why ascites is going on. So we will take we'll take the history of if there is any pedal sweating and paired swelling and periorbital edema is developed. So if here is a there is a pitting edema is bipedal pitting edema is there, but no periorbital edema is there. So in case of there, if there is any case of liver disease, the ascites will develop fast. Then pedal edema and the periorbital edema will develop. But if there is a if it is a case of heart failure, then pedal edema will be developed fast, then ascites. And if it is a case of renal disease, renal cardiovascular disease, CKD, then periorbital edema will develop fast. So prognosis of the edema is a very important thing. And if there is a malnutrition, like kwashiorkor, marasmus, then whole body swelling will be developed. Okay, so and then their sacral edema will also be seen. And rather than that, if there is an tuberculosis is there, so we can see that fever will be there. And another thing, for ascites, we'll see if there is the abdominal pain or not. Abdominal tenderness if there, if abdominal tenderness is there and abdomen is hard, then it may develop the subacute bacterial peritonitis. So total count of the ascites fluid will be increased then. And in ascites patient, if there is due to renal hepatic causes, we need to monitor GCS, because hepatorenal syndrome hepatic encephalopathy may be developed in any time. And in case of liver disease, you can see that jaundice will be there, and pallor will be there for chronic long-standing diseases. And massive splenomegaly is here due to the portal hypertension. And after ascites, the bipedal pitting edema is developed here, so we can see the bipedal pitting edema is there. And another cause there is that you can see that in next slide you have seen that albumin is also less here. So oncotic pressure is also low here. Oncotic, due to low oncotic pressure, and whole body swelling will develop gradually. Okay, thank you.